Okay, good afternoon to you all. You're all welcome to the session of today, whereby we are going to cover assessment and management of asthma in children and adults. And we are also going to cover emergency management of chronic obstructive pulmonary disease. So you're welcome once again. Our experts, you're welcome. Our panelists, you're welcome. And our online participants, you're very welcome. At this moment, we are going to introduce ourselves. And I'm called Parikonda Charity. I'm the area manager, emergency department, Barawicho Referral Hospital. And we are also joined by a number of experts and panels, and I request them to introduce themselves. Dr. Esther.
You're most welcome to this CME. My name is Dr. Esther Nagwire. I work with Ubaga Hospital, and I'm here basically to discuss management of asthma in children.
Thank you. Good afternoon, colleagues, and thank you for joining in. My name is Darlington Mwezi, and I'll be joining today's discussion. I'm a resident in emergency medicine at Makerere University. Thank you.
Thank you.
Yes, good afternoon, everyone, and welcome. I am Dr. Harry Chen. I am a CED Global Health Emergency Medicine educator at Makerere University.
Thank you. You're welcome, Dr. Harry. We are also joined by another expert who is online, and I will welcome her to introduce herself. Dr. Rachel, please. Dr. Rachel, you're welcome.
Good afternoon, team. Good afternoon, colleagues. My name is Ndada Nangobi, medical officer. Okay. Good afternoon, team. Good afternoon, colleagues. My name is Nangobi, pulmonology ward in Mulago National Referral. I'll be the case presenter for today.
Thank you. You're welcome, Dr. Rachel. We are glad to have you on our team. At this moment, I would also like to welcome Mr. Agawa, who is the clinical advisor, CED Global Health, and I invite him to give the welcoming remarks.
Thank you very much, moderator. My name is Dr. Agawa Brian. I'm the clinical advisor at CED Global Health that hosts these sessions alongside the Ministry of Health and other partners. I welcome you all to today's session that is difficult in breathing, with a focus on asthma and COPD. This session is part of phase 3 and is the first session in phase 3. Phase 3 focuses on approach to key syndromes. We are very excited about this phase because it addresses conditions that you see in your day-to-day work. And the premise of these echo sessions is to improve management of these conditions. So phase 3 has 14 sessions that will run from now until October with very exciting topics such as the one of today. We completed phase 2 and we're in the process of working on your certificates, and we shall begin distribution of your certificates in due course. I also have one other announcement about the resuscitation action teams that have been formed in your hospitals to improve care for emergency conditions. And we're going to begin by training one member from each team. This member has already been selected by your hospital mentor, and they will be training next week from Tuesday to Sunday. So look out for this. There will be more trainings of these teams in your areas. We also want to put out a call for experts and any other people who would want to be part of these sessions as our experts and moderators. We shall send a link for you to register in your emails. The email is provided to us, and also share a link in the chat. If you want to be a moderator, a trainer, an expert, please register and we shall contact you and put you on board. Thank you very much, and I wish you a wonderful session. Talk to you, moderator.
Thank you so much, Mr. Agawa, for those opening remarks. At this moment, I will come once again our online participants. Thank you so much for logging in. And as you can see, we are joined by a group of experts who have a lot of knowledge and skills in management of asthma and COPD. And we believe that we shall have a very educative session. At this moment, We shall have the pretest, which is being displayed on your screens. Please, we request the online participants to fill in the pretest. And during that time, we are going to have expectations from our participants. Please feel free to raise your hand or to write in the chat so that you can give us your expectations for this session. Thank you very much. So as we are going on, let's be able to pick our answers in the pretest so that we can be able to assess our knowledge before we continue with the session. One important thing is that today is International Nurses Day, and myself being a nurse, we congratulate all the nurses upon this day, and we appreciate all the work you do in the management of our patients. Congratulations, our dear nurses. The pretest is on our screens. Please let's mark the answers. What's needed? Yeah, the pretest is on. I hope all of you can see it. Let's be able to mark our answers and we submit so that we can continue with the session. And we are just going to have 4 minutes for that, so that we can.
The pretest.
How did they get to the pretest?
We are receiving expectations from the participants.
We can't see the pretest. We can't see the pretest.
The pretest is running. Please click under pause and quiz on your device. Then you'll be able to see the polls. If you're not having that tab down in your Zoom, what you should do is you click on the dots down, you go to more, and then you see pause and quiz. You'll be able to locate they're running because we are getting responses from some participants.
Okay, thank you. So as the pretest is going on, we welcome expectations from our participants. Please feel free, put up your hand or to write in the chat your expectations, please. Our dear participants, please feel free to fill in the answers to the pretest and submit so that we can be able to continue as we are still awaiting your expectations for this session.
So there is one expectation to learn about the management of asthma and COPD. There's an expectation about asthma and COPD. Which one complicates the other?
That's a nice one.
Yes, thank you for expectations. You are still receiving expectations. I hope all of you are doing the pretest and you're submitting.
Complications of asthma and COPD, medical treatment for asthma and COPD and possible complications, management of asthma in children, new drugs and treatment of asthma and COPD, criteria for first-time diagnosis of asthma and COPD. How to use a nebulizer.
Thank you so much to our online participants that have given in the expectations. And in summary, expectations received are treatment of asthma and COPD. Then there's an expectation of asthma and COPD, which one complicates the other. Someone wants to know the complications of asthma and COPD. Another one wants to know the management of asthma in children. Another one is interested in knowing the new drugs and treatment of COPD. And last but not least, someone wants to know how a nebulizer is used. Thank you so much for those expectations. And I believe that with the team of experts we have on ground, most of your expectations will be met in this discussion. But feel free to keep typing in your expectations in the chat, and we shall be able to capture them and we cover them. Thank you very much. At this moment, we are going to have our case presentation, which will be covered by Dr. Nangobi Rachel Ndada, Medical Officer, Respiratory Ward, Mulago National Referral Hospital. You're welcome, Dr. Rachel, to give us the case presentation. Dr. Rachel, you're welcome.
Hello, good afternoon, everyone.
Good afternoon.
Good afternoon, everyone. My name is Ndada Nangobi. As I had earlier introduced myself, I'm a medical officer currently in Mulago National Referral Hospital. So I hope everyone can hear me. In summary, we are having just a case of a 30-year-old female with difficulty in breathing. DIB is difficult in breathing. So brief history. I just hear comments, I didn't get enough time for the pretest, but the modulator will work on that. So we're having VR, a 30-year-old female from Nankulabia, the occupation. She has no occupation, just sits at home. Her presenting complaint was cough for 5 days and difficulty in breathing for 1 day. So VR was a non-asthmatic for a known period of time. She was able to support herself to hospital. With a dry cough associated with admission. So the patient had some, the second slide, the patient had run out of her drugs and inhalers 2 days prior to admission. She had had several admissions because of the same complaints, the cough and difficulty in breathing, and she would have these at least once in a month. And the last episode she had was about a month ago. The triggers for the current presenting complaint, the cough and difficulty in breathing, 1 was no drugs, and 2, she stays alone with very poor social support. So that is briefly about the patient. In the primary survey, when we examined the patient, the airway, she was in moderate respiratory distress, however, was able to talk. In the breathing, she had a respiratory rate of 20 breaths per minute. The oxygen saturation was at 90% on room air. And when we auscultated the chest, she had bilateral widespread bronchi. The saturation, she had warm peripheries, no pallor. The blood pressure at admission was quite high. It was 167 out of 129 millimeters of mercury. Equally, the pulse was quite high. It was 140 beats per minute. And the disability, Her GCS was at 14 out of 15, just because she had some confusion with the visual hallucinations. When we move on, the diagnosis that we made. So with all the, putting in summary, the examination findings and the history, difficulty in breathing, wheezing and cough, and then in a non-asthmatic with the widespread bronchial examination, the first diagnosis we made was acute asthma exacerbation. And then we were querying bipolar because she had visual hallucinations. Yeah, and in our plan, we had an immediate plan. The immediate plan was to nebulize with salbutamol, 5 milligrams, with 3 mils of normal saline, and IV hydrocortisone, 200 milligrams. And in our follow-up plan, one was to give her antibiotics, IV amoxiclav, then a tablet of montelukast, salbutamol inhaler, ascoril syrup, and then prednisolone. And another plan, we wanted to involve a social worker because she was alone. And then also discharge through the psychiatry clinic. In the post,
Dr. Rachel, we can't hear you well. Your network is not doing well. Is it possible to adjust and Dr. Rachel, are you there?
yes, can I go on?
Yes, please. Yes, Dr. Rachel, go on, please.
Hello? Well, on day 2, patient still had general.
Dr. Rachel? Okay. Since we cannot hear you well, Dr. Rachel, since we cannot hear you well, you could pause a bit and we discuss what you so far presented.
That was the.
Yeah, it's terrible.
Yes. Dr. Rachel, thank you so much for the case presentation. We note that your network is not doing well, but we are grateful for whatever you've presented already. And we request that we could meanwhile be discussing what you presented. At this moment, I welcome reactions to this case presentation from our online participants. Any reactions so far from our online participants?
So there's a reaction from Janet Barrow White. Obvious asthma without fever should not need antibiotics. Why add Corel when salbutamol given?
Yes. Dr. Nabire, I welcome you to answer that question. The question is asthma, obvious asthma without fever, should obvious asthma without fever need antibiotics? And why was aspirin given when salbutamol was given?
Okay,
Thank you.
thank you for that response. First, I'll start with the issue of antibiotics. Asthma exacerbation without fever does not warrant use of antibiotics because we know asthma is not an infectious process, much as it, we know these patients are at a risk of acquiring pneumonias. But if they do not have any symptoms, fever especially, antibiotics are not routine. However, it is not a one-shoe-fits-all. There are certain factors that you have to put into consideration. For example, sometimes you have patients who have had recurrent exacerbations requiring routine hospitalization, patients that have associated comorbidities and other medical conditions. For example, if a patient has asthma with a pneumothorax or asthma complicated by pneumonia, those will need antibiotics. But just an acute exacerbation without any other associated factors and features of infection, antibiotics are not encouraged.
Thank you so much, Dr. Nabire. Patrick, Angela Tumusime is asking, what normalized the blood pressure from 167/29 millimeters of mercury to 98 over something? Was any regimen given for the high BP? Dr. Darlington?
Well, I did not get what treatment was given, but from the presentation, usually when they are in that kind of stress, you note the increased respiratory rate, you note the increased heart rate, the tachycardia that was on there. And so maybe that could also have affected the BP. And if we give treatment, if she's gotten the nebulization, she's feeling better, then we expect that also the respiratory rate will go down. So does the heart rate. And that might also eventually affect the BP. Though I don't know if she gave an antihypertensive in the process or what the other issue was. So to me, I think maybe it was the management that was given for the presentation at the time, and then the response to the treatment. Yeah.
Thanks so much, Dr. Darlington, for that clarification. And there are many more questions coming in, but most of them have been answered already. They are mostly about the antibiotics. Maybe one specific question.
Excuse me, moderator.
Yes, please.
Yeah, I just wanted to give feedback. Someone was asking about anything done for the blood pressures.
Yes.
So we did not do anything. And then the next time of follow-up, the pressures had come back to normal. So probably it must have been the trigger that put her pulse rate and the blood pressure high.
Okay. Yes, Mr. Christopher Wako. We welcome your reaction to the case presentation.
Thank you, moderator. My name is Christopher Wako. Mine is one small one. Always when we get patients in exacerbation, there's a feedback. I'm sorry. When we get some patients in exacerbation, we tend to give a SABA, a short-acting bronchodilator, like it was given in this case as an inhaler, and we give the patients injectable corticosteroids. My concern is there a role of giving an inhalation corticosteroids together with the short-acting bronchodilator, such that control the exacerbation, and also we give a preventive? Thank you.
Okay, thank you so much, Mr. Wako, for that question. Dr. Nabire, please.
Okay, thank you so much for that question. Yes, there's a role of inhaled corticosteroids in management of acute exacerbations. However, most guidelines recommend that if you give optimal doses of just the SABA, that should be sufficient to actually do away with the exacerbation. In the event that you do not have access to a SABA, but you have an inhaled corticosteroid, for example, budesonide, that can be used as well, but the effect would be much less because we know the SABA, the onset of action is quite really quick. In about 5 minutes, you start to see a response. But the inhaled corticosteroid the onset of action is quite longer, and so if you have a severe exacerbation, it might not necessarily help relieve the exacerbation immediately, but it indeed plays a role in management. But most importantly, it plays a role in controlling the therapy after the exacerbation.
Thank you so much, Dr. Esther, for that clarification. And for the other questions, they are being replied by our emergency physician, Dr. Harry, on the chat. Please let's keep on checking on the chat, and we shall continue with some of the reactions in the question and answer session. Thank you very much. At this moment, we are going to cover assessment and management of asthma in children, and I take this privilege to welcome Dr. Esther to take us through that part. Dr. Esther, please.
All right, thank you so much. We are going to basically talk about assessment, but before we go into assessment, it's important for us to understand what do we know so far about asthma, because we're here to manage emergency management of asthma, but first importantly for us to know. So we know that asthma is a chronic illness of the respiratory tract that has two defining patterns. The first pattern is a history. If we can reference from the case presentation that has been presented, there must be a history of respiratory symptoms. And commonly these symptoms, they vary over time and they vary in intensity, and they are commonly, we see that these symptoms are commonly triggered by certain environmental factors, pollen, dust, any form of allergens, and also significantly, alongside the respiratory symptoms, you must have expiratory outflow failure or difficulty in expirating air. That is ability for you to blow air out of your lungs. So in acute asthma exacerbations, this means that the patient is either already a known asthma patient or a newly diagnosed patient, probably not even known, but they present with what we call flares up or an attack. Common in the community, they are known as asthma attacks. This is when the symptoms have become worse, the severity has increased, the frequency, and this usually is accompanied by inability for you to carry on your daily activities. So the severity, when we come to the assessment, the most important thing we have to do is to assess the severity of the attack. Basing on the symptoms our patients presented with, it seems like this patient had a mild asthma attack, borderline between mild and moderate. We have three categories where we have the mild asthma attack, the moderate, and the severe. So when you're first with a patient in your emergency department or wherever you are, the most important thing for you is to assess severity. How do we assess severity? We have a pediatric severity assessment score, and I think this cuts across in the adults as well, where we look at certain things like the level of consciousness. As your patient come in normal, they are alert. Is the patient confused? Is the patient restless? Any patient under confusion is a severe case. Restlessness is moderate, and then those who are normal, that is mild. So the other things that can actually point us to a severe asthma attack is when you have inability of the patient to speak. They're usually able to just make a few words here and there, but they're not able to complete a statement or make a phrase. They commonly have what we call a silent chest. Silent chest means they do not have any movement of their chest cavity. So they are not blowing in air, they're not blowing out, and that is actually a sign of impending respiratory failure. Some of the other things we look at, commonly done in the emergency room, our respiratory rate is usually increased, the pulse rate, the oxygen saturation. Anything below 92 is severe asthma attack. 92 to 95 would give us a moderate, and anything above 95 should be normal. So these are parameters that we use to assess the severity. Once we have assessed severity of the asthma, then now we decide how do we go ahead to manage. And the beauty is a lot of this assessment is done basing on symptoms, and then the clinical findings, which can be done in any setting, regardless of wherever you are. So how do we go ahead to manage? Mild asthma, usually you have the typical symptoms: cough, wheezing, chest tightness, some shortness in breath. And these ones usually benefit from the SABA. SABA is a short-acting beta agonist. And the common one we use is salbutamol, which we can deliver either by nebulization or by inhalation with a spacer, which we shall have a look at before the end of the presentation. So a single dose of salbutamol should be sufficient to take the patient out of a mild asthma attack. And if after the first dose they are still having typical symptoms and respiratory compromise, then you can repeat the dose. However, if after the second dose of salbutamol there's no improvement, then this is a patient who actually graduates to mild to moderate asthma attack, and then now we have to come to the additional treatments. So with the moderate asthma attack, we are going to add just one more additional drug, and that is ipratropium bromide. This is one of the mainstay treatments in asthma. Ipratropium is an anticholinergic, right? It's an anticholinergic. So it works by causing bronchodilation, but it also has an effect on reducing the mucus production within the bronchioles. So when we combine the salbutamol and ipratropium bromide, it gives us a better effect. There are some people who think if we use ipratropium bromide alone, it should be sufficient, but salbutamol's onset of action is about 5 minutes. Ipratropium bromide takes about 15 to 25 minutes. So it wouldn't help you relieve the symptoms if you used it alone. But the combination of the two actually provides synergy, which causes a rapid response. And this is what we use in moderate asthma. It is also very important to note that when a patient has features of moderate attack, this patient will benefit from oral steroids, where we can use prednisolone, we can use dexamethasone, any of them, whichever is available, really. None of them overweighs the other in terms of benefit, maybe in terms of cost and availability and other. Then when we come to severe asthma attack, these are actually some of our patients that we meet in our emergency departments. These patients usually come in confused, wheezing, poor respiratory effort. To the worst, they have a silent chest, they have a tachycardia, the respiratory rate is high up in the roof. So these are patients, still the first line treatment of management of asthma will always be a short-acting beta agonist, and this is salbutamol. So for severe asthma attack, we use salbutamol alongside ipratropium, but we also bring in the aspect of inhaled, rather intravenous corticosteroids at this point. We will briefly talk about the doses. For the pediatrics, we use salbutamol about 2.5 mg of salbutamol in normal saline, where you can use about 2 to 3 ml of normal saline. And you can actually go ahead to nebulize every 20 to 30 minutes for the first 120 minutes. That's for the first 2 hours. And if there's no, when your patient improves, then we can start to taper down the frequency and probably take it down to about 4 hourly, 6 hourly, depending on your patient's response. In the severe asthma, it's important to note for moderate and severe asthma, where we have our oxygen saturations coming low, it's usually advised that this salbutamol and ipratropium is oxygen delivered. So these patients benefit from oxygen therapy. Very, very important, because hypoxemia alongside accumulation of carbon dioxide, that's hypercarbia, it can actually result in metabolic acidosis and progressive mental incapacitation. I think I've mentioned about salbutamol, ipratropium, and steroids. One of the most common things most people usually ask is, what happens if I do not have a nebulizing machine in my unit, or if it is faulty? The routine salbutamol inhalers that we use for control therapy in our homes, the Ventolin or any other brands of salbutamol, are usually sufficient for you to control a mild and moderate attack. And what we usually recommend is about 4 to 5 puffs, rather 4 to 8 puffs. And that is equivalent to about 2.5 to 5 milligrams of salbutamol. So the same way you would nebulize a patient is the same way you get their inhaler, correct the technique of use, give 4 to 8 puffs every 30 minutes, until you have response. So those are the basic drugs we use in the management of emergency management of asthma in children. There are so many other drugs that have been used in the past that we also use in very severe forms of asthma. For example, magnesium sulfate is one of the new drugs. We use magnesium sulfate when the salbutamol and ipratropium combination has failed to relieve the symptoms. So magnesium sulfate becomes like the third line. First line being salbutamol alone. Second line is salbutamol alongside ipratropium. Then the third line is magnesium sulfate, which also has similar mode of action. It causes smooth muscle relaxation, bronchodilation, and also reduced mucus production. But this one we use in very severe forms of asthma, and it is given intravenously. I think we'll give a comment on the other drugs that we have phased out at the end after we have discussed management in adults. Thank you.
Thank you so much.
So Dr. Patience, I have a couple questions from the chat. One is, maybe you could talk about in children, what's the dose of corticosteroids you would recommend?
Okay, so for steroids, it depends on what you have. What we have on the market here, we have prednisolone. The dose of prednisolone is 1 to 2 milligrams per kilogram per day, which you can actually give in divided doses, 2 to 3 divided doses a day. We can use dexamethasone, which is common on the market, very cheap and accessible. Dexamethasone, the dose is 0.6 milligrams per kg. And what sometimes usually makes dexamethasone superior is the taste of the medicine, the cost, and the fact that for dexamethasone usually require either 1 or 2 doses. While for prednisolone, you'd need to dose for about 3 to 5 days. Yeah. Then for the intravenous steroids, we can use IV hydrocortisone, even IV dexamethasone also works.
So thank you very much. I think you raised some very important points. One is about the single dose dexamethasone. With a child, sometimes it's hard to get them to take medicine. And I think the other point about the inhaler is really key. There are many places, many pediatric emergency departments and adult ones that only use inhalers. They always use them with spacers though. And obviously they have to be awake and cooperative to be able to do that, but it works just as well.
We are going to have a demonstration of how to use the inhaler with the spacer in the event that you don't have nebulization available.
Okay, thank you so much, Dr. Esther. Peter is also asking, how about the use of salbutamol and atropine when they don't have ipratropium?
Atropine, no. No. Salbutamol alone should be sufficient. If you do not have access to ipratropium, then you combine your systemic steroid alongside salbutamol. And remember, salbutamol has given us an allowance to repeat the doses at least every 20 to 30 minutes until we have response for the first 120 minutes, and failure to do that, then now, because if your patient is not responding to a bronchodilator, then you have to ask yourself why. Probably it's another diagnosis. But in absence of ipratropium bromide, salbutamol is sufficient.
Okay, so thank you so much. So let's refrain from the use of atropine, and we are able to use what doctor has talked about. Another question is that in the case presented, they used montelukast for the case. Someone is asking that, is it safe in pediatric patients?
Yes, it is. Montelukast is it's a leukotriene modifying agent. Yes. Receptor antagonist. So what montelukast does is that During its mechanism of action, it inhibits the release of
Basically, also
antihistamines.
it
Yes.
also relieves the swelling and also, that tightening of the airways. So it causes also.
So it is safe in our children. However, montelukast is not an emergency drug. So when we come to talk about emergency, we are alleviating the exacerbation. Montelukast is a drug we use for follow-up care and maintenance after the acute onset has been cleared.
Thank you so much. I hope, Nelson, you've got that. Someone is also asking a clarification about hydrocortisone. You've talked about the use of other steroids here, specifically you've talked about prednisolone and dexamethasone. And in our settings, people have a lot of hydrocortisone and they usually opt for that. So any comment on that in pediatric patients?
Hydrocortisone, if you remember during my presentation, I mentioned we use hydrocortisone in severe asthma attack. If your patient is able to tolerate drugs orally, we always recommend for the children, oral steroids are the mainstay in management of asthma, whether it is mild or moderate, provided there is no vomiting and they can tolerate it well. It's in our patients who have severe asthma where we bring in hydrocortisone, but it is safe.
Okay. Thank you, Dr. Esther, for that clarification. And I hope our participants have got it, that hydrocortisone is always used in severe asthmatic attacks, but prednisolone and dexamethasone, the oral corticosteroids, are usually well tolerated in children. On the chat, still someone is asking about magnesium sulfate, though of course you did not talk about it, but you could throw more light on it.
Okay, I mentioned magnesium sulfate. Magnesium sulfate is the third line. It's the third line treatment in acute asthma exacerbation. Magnesium sulfate is a smooth muscle relaxant. So it will cause relaxation of the muscles in the bronchi, and by that relaxation, we are going to have bronchodilation, which will give us the effect we are looking for. Other studies show that magnesium sulfate also has an effect on the mast cells and also decreases mucus production. And we have already understood that what is happening in an asthma exacerbation, we have bronchoconstriction, increased mucus production that causes plugging and also hyperinflammation. That is why we have the three mainstay drugs: the SABA, salbutamol for bronchodilation, the steroid for the inflammation, and then the other treatments that we have mentioned about.
Thank you very much. This is to Dr. Darlington. In the special groups in pregnant mothers, I know this is not the right time, but since it's asked, we may forget it. Someone is asking about the right management of asthma in pregnant mothers, and he's saying that is it possible to give the outlined drugs, the ones Dr. Esther has mentioned in pregnant mothers, or are there any contraindications?
Still in the pregnant mother, the management the principles of management are the same. So you're doing the assessment, like Doctor went through, and then you're giving them, according to that hierarchy. So the short-acting the SABA is given first, of course, and then you follow through. The steroid might not be given at that time, of course, depending on the level of pregnancy. But if it is also, I know we give steroids towards the third trimester. Yeah, so that would also depend on the timing of the pregnancy. And we also know that we give magnesium sulfate for other complications in pregnancy. So I think it would still be safe if somebody also came in status asthmaticus. So yes, I would still follow the same cycle.
Maybe to supplement what Dr. Darlington has mentioned, management of asthma in pregnant women, the benefit of the drugs outweighs the risk.
Yeah.
So there's no difference. We follow the same protocol because at that point, if you have respiratory compromise, ultimately it would also affect the fetus as well. So benefit outweighs the risk.
Thank you so much. We shall have one last question. People are interested in knowing whether aminophylline is still in use and the dosage of magnesium sulfate in pediatric patients.
Okay. No, we don't use aminophylline anymore. It is not recommended. It hasn't been shown to have any benefit in mild, moderate, or severe asthma. And so we don't use it anymore. It has been totally scrapped off the new guidelines. Please do not use aminophylline. The dose of magnesium sulfate is 25 to 50 milligrams per kg, and it's given intravenously over 15 to 30 minutes.
Thank you so much.
And the dose of magnesium in adults is generally 2 grams.
2 grams, yeah. Given over 20 minutes or so as an infusion.
Okay, thank you so much, Dr. Harry. So the dosage of magnesium sulfate is 2 grams, and it's given IV. And Dr. Harry had already commented in the chat. Please let's check in the chat for the dosage. And someone is also asking, use of adrenaline and hypertonic saline during nebulization, during a severe exacerbation. Please comment on that. I think some centers still use adrenaline, that combination, and they kind of want a comment on that.
Maybe Dr. Harry can tell us about adrenaline.
About adrenaline.
Use of adrenaline and hypertonic saline during a severe asthmatic attack.
I mean, I can really try to address the adrenaline. There are, extremely rare cases where you might want to use an intravenous beta agonist, but by far and away, you can treat people with less side effects by using your short-acting beta agonist. So really, whether it be a continuous nebulization of a high dose of salbutamol might be one option. Magnesium sulfate, you might even try to use some non-invasive ventilation and then, if you're really in trouble, I certainly think some people would use some kind of parenteral beta agonist potentially. And it could either be terbutaline in the US or adrenaline. But again, that's really a more desperate solution than standard therapy.
Thank you so much, Dr. Harry. Tom Ogwany is also interested in knowing whether magnesium sulfate is given in a percentage of 20 or 50, especially in pediatric patients. 20% or 50%?
That would be a tricky one. I'll respond to that shortly.
Okay. Tom, please hold on. It will be responded to shortly. And thank you so much, our online participants, for all your questions. And I take this opportunity to thank Dr. Esther for the presentation. Well done in children. And I believe the participants have gotten a lot of skills and knowledge. At this moment, I welcome Dr. Darlington to present to us assessment and management of asthma and COPD.
Okay, thank you very much, moderator, and thank you, my colleague, for your excellent presentation. So she has handled most of the issues that we deal with with asthma. So just a recap. So the assessment we follow the ABCD protocol in the emergency room. So A for airway. So you assess the airway pattern, or is it threatened by any comorbidity or morbidity? Yeah. So if there are secretions, excess secretions, for example, or if somebody, as we shall see in the worst case scenarios, some of the issues to be affected are the state of mentation. So if you have altered mentation, their GCS is going down, then you're thinking maybe this is somebody who might need an airway protection, but that is in very severe cases. So the airway patency and the need for securing it has to be noted. Then you're going to the breathing, of which you note the respiratory rate, just like we saw in the case presentation. Initially, the respiratory rate was high, and after management, this respiratory rate was managed and it came a little bit lower. So you're looking at respiratory rate, you're looking at the chest movements, you're looking at the work of breathing, how much effort are they putting in, and they're going to get tired, okay? The issue with the assessment in the ED, one, you need a team, you're not working in isolation, and because you have a team, then you can also intervene as you go along, okay? So if you have determined somebody needs oxygen, then you determine what best modality to give oxygen, and you give it at that time, and then you continue. Then you also, in the A&E, we do not get tired of reassessment. So every time you do an intervention, you come back and assess what has that had on the status of the patient at that time. And then you realize you need to either to repeat or, escalate intervention. So that is the A, the B, the breathing bit, and of course you listen to the chest. In asthma, one of the biggest issues is of course wheezing. There will also be breathlessness. There will also be sometimes, there might be a cough. So those issues are noted. So when you listen to the chest, you might be able to get that. Then the circulation is very important, especially if there are also other comorbidities involved. For example, any sort of cardiac abnormality or heart disease might complicate your management. So that is also important. So you note the pulse rate, also capillary pulse rate, BP. As you saw in the case, initially the lady had a tachycardia and also and a high BP, but this was actually came down after the initial management. So those are the issues that we need to do. Of course, the D, you're looking at the mental state at the time. The GCS is very important to capture. And also, it is also good to determine your response to treatment. If it is worsening, then it means the patient is not responding appropriately. And if there is an improvement, then you're thinking that your interventions have been effective, and then you can, adjust treatment accordingly. So that is the D. And of course, the rest of the issues that we deal with, your blood sugar and all that, also done at that time. The exposure, you look out for things like the temperature, because if there's a fever, then we're thinking what could have been the trigger is maybe an infectious process going on. So that needs to be managed also. And that will be the same even for COPD. So that is also noted. And then you do the general exam, and you look out for any comorbidities and other presentations that need to be managed along with that. So it is an entire system to assess and also then manage the patient appropriately. Now, the relationship, not the relationship per se, but she's discussed most of the asthma, so probably I would talk more about COPD and then maybe a few differences between COPD and asthma. So COPD, we see that asthma, when you give the short-acting beta agonist, then we are supposed to get, an improvement. You're supposed to get a relief, ideally. However, in COPD, because the situation is more chronic and the damage is, the process of damage is different, so there is chronic inflammation, so it is not going to respond immediately. There's still a role of the SABA in the management of COPD, as we shall see, but it's not going to give that level of relief that you get with asthma, and that forms the mainstay of differentiation, where it is, especially in adults, where it can be difficult to make that difference. So both have airflow obstruction, but in asthma it's more reversible compared to COPD. And then of course in asthma also it's more episodic. So either they might get an exacerbation at night, or when it is cold, or in the mornings, or when there is some sort of trigger. While for COPD, it's more ongoing. So it does not, change in presentation as rapidly as it does as in asthma. So if you have that presentation like in an adult and you give a bronchodilator and a SABA, and the patient responds immediately, then you're thinking, no, this might not be COPD. So you're making, your kind of the diagnosis. Then COPD has other issues involved with it. The presentation, usually there's just like in asthma anyway, there's dyspnea or difficulty in breathing, but also importantly, there will be a cough, and that cough usually has usually productive of sputum. And then the COPD also has a huge effect on the quality of the life somebody lives. So there is a very easy, they get a stress or difficulty in breathing on exertion, okay? So, but they might not report this because they subconsciously reduce their level of activity just to cope with the situation. So it does affect their quality of life. That is one thing that you look out for. So how we assess somebody for COPD, of course, I've just gone through the ABCD. You follow the same for COPD. and then you manage as you go along. But importantly also in the history, there are things that you look out for, okay? So you look out for, of course, chronicity, issues of family involvement, and then especially for exposure, smoking, very important. Every smokers, of course, the heavier the smoker, the higher the chances, or the higher the risk for developing COPD. It doesn't mean that people who do not smoke do not get COPD, they can still get it. Also, the smoke and other pollutants, vaping, also passive smoking, occupational risk for people who work in industries where there are fumes, dust, mines, for example. So they tend to present with those kinds of issues later on in life. I should add, of course, that these are usually in adults, usually after middle age or so, though they can also be early onset, in which case you're looking at disorders maybe alpha-1 antitrypsin deficiency. Then there are other issues that come up. There are issues to do with infections. If you have had history of bronchiectasis, for example, history of TB, in HIV, like in our situation here in Uganda, then you're going to get all those issues coming up. So you're doing that as part of your history to try and see what situation you're dealing with. As we shall see, the differential diagnosis can be quite wide. So you still have to make the differentiation. And because you do that, then because you can provide proper management, which will improve the quality of life of the patient and also be able to prolong their lives. Now, in the ED, what we need to look out for both for asthma and for COPD is a level of severity. Because if you don't assess this, then we might get the person worsening or, probably then, getting into arrests, respiratory arrest or something. So what are we looking for? We are looking for that increased work of breathing. You're looking for physical signs like cyanosis, inability to maintain respiratory effort. So somebody is basically tiring out, okay? So it becomes hard for them to breathe normally. The mental status is affected. Initially, it will just be, maybe a bit of confusion or something. So it doesn't have to somebody be in coma and all that, but they will still have mental status being affected. SpO2 for asthma, you mentioned, I think, the target 92 to 95 or so. For COPD, they usually have lower SpO2s. So usually between, even for treatment, when we give oxygen, you're targeting maybe between 88 and about 92. If we go higher, we shall see that we reduce the hypoxic drive, and then somebody might not be able to respond to their own body system. So even when we give oxygen, we need to give it sparingly, not to get them into issues. Doctor talked about the issues of speech and silent chest, of course. So inability to speak. You're speaking in single word. The positioning, usually sitting forward. They don't like lying down because once they lie down, it becomes even more stressful. They are agitated. They sweat a lot. So basically, the state of the patient should be able to direct you to what state of the severity the person is in, and then you're able to direct your treatment accordingly. Remember to have a team with you so that you can identify these features easily, and then you can manage them. Now, depending on our settings, of course, when you identify this, it also depends, one, on your expertise, and two, on the available resources. So an earlier identification of somebody who might worsen or might deteriorate, one, you need to treat them timely. Two, if you think that they need a safe transfer, then you're able to initiate the processes for you to take them to a place where they're going to be appropriately treated. This shouldn't come when the patient is really fading. It should come earlier, because the later you do it, then the higher that you're going to get complications being worse for the patient. So timely interventions are very important. I talked about the history, the environment. Okay. So now what we do next, we go to the examination. You've done the assessment. You do also the physical exam and the chest exam, and and look out for any factors that could have precipitated this exacerbation. Usually what brings them to the A&E is the exacerbation. They've had their COPD before, it's been chronic, they've been on home therapy, but right now they're coming back because there's an issue. Usually an infection, so look out for that. If there's a fever, if there's a new productive cough with purulent sputum, for example, that is somebody that you need to look out for. And then the other symptoms we talked about, the dyspnea, the cough, and the wheezing. And then, of course, you're also looking out for the comorbidities and also managing them. Diagnosis, we need to, of course, the history and the physical exam. Then specifically for COPD, we need to do spirometry. And of course, I know the limitation in the number of centers that can ably do this, or the expertise. So if we need, after the initial stabilization, later when the patient is more stable to undergo these tests, because they can be strenuous. So you need to refer to a center that can do this. And what they look out for is the first expiratory volume in 1 second, FEV1, and then also the first vital capacity, and then the ratio. FEV1 on itself can be diagnostic, and it can also show the severity. But then also the ratios also help, the FB and FVC ratio. And then for mild, if you're comparing the ratios, if you have about more than 80% of the predicted value per individual, because these differ between individuals, then you're thinking that is mild. For moderate, 50 to about 80 of the same ratio, and then severe is under 30. So if somebody is in severe, then you're thinking they need a different level of management. So why you're classifying this is that they have different management modalities, as we shall see. Then FVA1, so mild also about 50 to 60 of the predicted value, and then moderate, that is 30 to 50, and again below 30, you're looking at severe. Of course, other supportive tests as you go along, the ABG is very important in centers that have them, and also have expertise to interpret them. The chest X-ray is important, but again, we shall see more of hyperventilation in it, especially in conditions such as emphysema leading to COPD. And then, of course, in the A&E, importantly, because it's a bedside test that is very simple for us to do and also to monitor, pulse oximetry. And the pulse oximetry is because we need it to monitor the patient and also to guide especially oxygen therapy. As I mentioned before, targets between 88 to about 92%. So when we come to the management, importantly, you do the ABCD and intervene, but again, oxygen therapy, target for SpO2, 88 to 92. This can also be done at home, and usually they need quite a number of hours on the oxygen machine. The delivery is usually about 15 or so per day, so it's quite, you can see the effect it has on life. And then 2 is that while we are giving medication, same as for nebulization, sometimes some of these interrupt oxygen supply. So we need a method that has capacity to deliver oxygen at the same time as deliver the drug that you're giving, such that somebody doesn't get affected. I mentioned why we need the oxygen being maintained around that range is that we want to not to interfere with the hypoxic drives. If somebody is anxious or something, maybe you might need an anxiolytic and all that. Then bronchodilator, a little bit of effect, but not as effective as compared to asthma. Okay, so but we still give it, and it also helps in mucociliary clearance, so they are able to cough out much easier, and that relieves a bit of the stress that they have. So still it is the nebulized beta agonist. Then anticholinergics, we talked about the ipratropium bromide, it is still given here. 500 microgram, about 6 hourly. And then there's also tiopromium, it's a TAP. I don't know if it is the pharmacist, is it already available? Yeah, so we need to check for that. Yeah, so, and if it is easy. Then steroids, they might improve airflow obstruction. but this is on an individual basis. So it's not general like we saw more in asthma. So this one you have to be more selective. But then also importantly, if there is an infection and you think it is the cause of the exacerbation, then we need to avoid the steroid. Okay, so it has to be specific for individuals, not anybody. If they think there is an infection, just avoid the steroid. Antibiotics, we discussed them already extensively, and asthma, it's the same discussion here. If there is an infection, if there is a fever, or maybe CRP is high, or you have a clear infective process going on, you can give an antibiotic. If there is no clear-cut infection, then the antibiotic won't have an effect, and you're just causing antibiotic resistance and all that. So it is something that we need to avoid if it is not necessary. So they have to be very specific why you prescribe an antibiotic. Same situation here. Then supportive measures, chest physiotherapy to try and ease the breathing, ease the coughing, clear secretions, clear phlegm from the chest, so the person can breathe a little bit easier. Nebulized mucolytic agent to help in breathing still and clearance of secretions. Okay. Also suctioning, especially for the very sick ones, might be very important to reduce the secretions. Yeah, and then yeah, maybe in some cases you might need to do a bronchoscopy if you think there is a clear obstruction that might need to be relieved or something like that. That is, of course, at a specialized level where somebody has the skills to do the bronchoscopy and also to relieve that kind of obstruction. In COPD, of course, we also give the oxygen therapy depending on the presentation. So initially, the nasal prong, the mask, maybe venturi mask, and then for more severe cases, you're thinking non-invasive ventilation, CPAP and BPAP and other methods to use in COPD. But these are for quite sick patients, but they are not moribund, okay? They are not that sick. If they are sicker, then you might need a more aggressive intervention. So, of course, you also want to intervene early so that you do not get to the worst case scenario. So these are sick patients, but they are fully conscious, and so they can tolerate the NIV. They are hemodynamically stable. So you're talking a relatively stable patient where he's sick, they need support, respiratory support, and then you think those ones can receive NIV. And then also the secretions are not too much. And then the comorbidities, maybe they do not have, other underlying comorbidities that are severe, okay? If you go beyond this, then you're thinking a state where you might need mechanical ventilation. So you're thinking, invasive ventilation, which requires an intubation. And of course, that's a very sick patient. So you're looking at somebody with extensive secretions. They are probably unconscious or tending towards unconsciousness. They are in impending respiratory arrest. Don't wait for them to first get into an arrest, because then they might not get out of it. So then those ones, you put them, you sedate them and you're going to tube them, and then you can put them on mechanical ventilation until such a situation when they are much more stable. The targets are that we limit the duration of the intubation. So you want, when they are stable, then you want to be able to wean them more faster and maybe extubate them, and you're hoping maybe they will be stable by then. The PaO2 target may be about 55 millimeters of mercury. You're aiming at normal PA carbon dioxide or permissive hypercapnia, so you encourage them to breathe on their own. Then you also want to leave them to, maybe if possible, depending on the status, maybe like CPAP or something, as in the minimal support that you need to give to be able to maintain normal, close to normal physiology, patient physiology. And then you adjust, of course, to patient management. And then, of course, you want to avoid barotrauma. And for that, you're looking at low tidal volumes and also low respiratory rates, something like that, and also a low inspiratory to expiratory ratio. So, but those are specifics for our people in the ICU and also the A&E. So if you have a patient whom you have assessed and they are getting to this level, and you do not have this level of support at your facility, then you're thinking we need to get this person to be assessed for safe transfer, and then we transfer them to a facility where they're able to get all these interventions timely so they can get a better quality of life. So, so what you're looking at for intubation, you're thinking respiratory arrest pending, loss of consciousness and all those things. They are so agitated, so you need to probably sedate them. That is when that issue comes up. And then also hemodynamic instability, low BPs or very high BPs or something like that, those gasping for air. Respiratory rates, even in asthma, they're above 30 or 35, then you think somebody is going to get into a respiratory distress because their work of breathing is too much and they're going to tire out. So, and of course, inevitably, the GCS, very important. So once these have been stabilized and maybe they are much more stable now, then you're looking at how are you going to manage them at home, home care, continued chest physiotherapy, oxygen supply at home, and then also a check-in on the vitals, and then a follow-up as might be needed to try and improve the quality of life of the patient. So as you can see, COPD can be severely it affects the quality of life that much, and also shortens lifespans. So it is why we need to assess it early and then to also manage it. And where we need specialist support, then we look for it. For example, issues like spirometry to determine the exact levels of severity and the support that will be needed for each individual patient. This treatment, we have general principles, but at the end of the day, it is tailored to the individual for you to get maximum benefit out of it. I think that's largely it that I had, unless we have any additions, questions.
Okay.
So thank you so much, Dr. Darlington. I think that was really a very good presentation. And I just want to kind of underscore a couple points that he made that are very important. I think one of the, some of it's what's the difference between asthma and COPD, people want to know in terms of treatment. And I think one of the keys is that the beta agonists do not work nearly as well in COPD as they do in asthma, whereas sometimes the anticholinergics can actually work a little bit better, relatively so. So the ipratropium may be much more helpful than in a COPD patient than actually in an asthmatic patient. I think the other the thing that he mentioned, which is important, is oxygen. When somebody with chronic lung COPD comes in to your setting, you don't want to put a non-rebreather mask on them.
No.
Because many of them actually depend on a hypoxic drive to breathe. Normally, our CO2 causes us to breathe, but once we are chronically have chronic obstructive disease, you actually rely on that hypoxia. So you probably should start off with these individuals maybe with 2 liters by nasoprom, and you want to titrate it, as he said, to maybe 88 to 91, 92%, not much higher than that. Otherwise, if you put them on it, a high flow, they may stop breathing, and that's the thing that you don't want.
Yeah.
He also mentioned non-invasive ventilation, very important and very useful, especially in COPD patients. And can buy you time and actually prevent the intubation. And I think the key, the difference with intubation is that in COPD, you can actually often help people for a short time with intubation and ventilation. Whereas with asthma, you're asking for trouble when you intubate an asthmatic, because you have not solved the problem. The solved problem with asthma is smaller airway obstruction. And now all you're going to do is put a lot more pressure in that small airway obstruction. So really, you really are loath to intubate an asthmatic, whereas you could actually use that as a strategy in a COPD patient. Finally, that certain patients with COPD, obviously we don't want to use too much antibiotics, but somebody with chronic bronchitis that comes in and tells you their sputum has changed color from white to green or yellow, can be very helpful to put them on an antibiotic aimed toward respiratory pathogens, and also increase their steroid doses. Because many of them are actually on chronic steroids as opposed to asthmatics, which tends to be kind of exacerbations and then remissions the COPD patients tend to have more of a chronic disease and can oftentimes be on chronic steroids and be very steroid responsive. There was also one question, maybe you could repeat again, of the dose of ipratropium.
Ipratropium, it was 600 microgram. 1 minute. Yes, 500 microgram nebulized every 6 hours. Then there's a tiotropium. It's a tablet, which I think would be much easier to take. It's just 1 tab OD, but I didn't get the milligram. Yeah, but it's same anticholinergic. Yeah.
Thank you.
Thank you so much, Dr. Darlington, for that wonderful presentation. And I hope all the participants have got the knowledge and skills in management of asthma and COPD in adults. And I also take this opportunity to thank Dr. Harry for the supplements and for the clarifications. At this moment, we welcome questions from the participants about assessment and management of COPD and asthma in adults. We welcome 2 or 3 questions from the participants. On the chat, Kathy Nakanwaj is asking Dr. Darlington that is there a situation where you can have 2 conditions overlapping, asthma and COPD, and if it happens, how do you manage?
Yes, you can have a chronic asthma eventually turning into a COPD, and as I mentioned, you assess that by how rapidly can it respond to short-acting beta agonist. In asthma, it's usually going to be more responsive, but as you tend towards the COPD, it's not going to be responsive. And then I should add that there are quite a number of other conditions that might mimic or they actually contribute to the presentation of COPD. You have emphysema, you have bronchitis, you have bronchiolitis, and then a different diagnosis, but maybe that might contribute if you have bronchiectasis. And then if you have other lung conditions, this might be more acute probably, like a lung cancer, either from bronchogenic itself or from metastasis. So any of those can complicate or mimic or almost present as. So that is why we're saying, how do you make the diagnosis, the chronicity of the presentation, and then if you've also done those specific respiratory tests, the spirometry, to help you to rule out those different conditions. So there is, yes, an overlap can occur, but then you need to try and differentiate which is what, so you can give appropriate care. Because once you get the diagnosis, then you probably know how best to manage the patient.
Thank you so much. And I think in what you've mentioned, it answers the question of other differential diagnosis.
Yes, those ones I've just mentioned. Those ones I've just mentioned. They're all part of the differential. Yes, also maybe an pneumonia, but it wouldn't be. It would be more acute and usually with fever. Then in our setting, I mentioned TB, but there's also TB associated COPD, and also because of the immunity being affected in HIV, then they can also get into situations like that.
Yeah. Thank you so much for that clarification. Another question to you again, Dr. Darlington. Can per-oral acetylcysteine be used in the management of excess mucus production?
So I think that's a mucolytic agent, right?
What?
Acetylcysteine. Acetylcysteine.
Yes.
Yeah, so yes, it can help in to make the flame much easier to cough out. So yeah, but I think it is more of a nebulization, or is it taken orally?
There's an oral,
Can be put in with an
oral
Yes.
and acetylcysteine.
Doesn't have a lot of evidence base.
Yeah. Okay, we've had, so the Dr. Chen mentions that the evidence is not that much. Yeah, but it can be given orally and also by nebulization. Yeah.
Thank you so much.
Okay, thank you.
At this moment, any questions from the?
I have a question that maybe the patients can answer. The relationship between, probably more in kids, between GERD and asthma. I don't know if you have any thoughts on that.
Yeah, there's quite a number of studies that have been done that we have seen a lot of asthma diagnosed at an early age being linked to GERD. GERD is esophageal reflux disease, where we have reflux of gastric contents into the esophagus. So there has been an association, but the association is not very clear. Quite a number of systematic studies that have been done have not really reached a conclusion, although they have come with that association.
Okay, thanks so much, Dr. Esther. For the meantime, we are going to go to demonstrations of some of the gadgets that are used in management of asthma and COPD. And I will welcome the experts to demonstrate to us some of the gadgets used in management of
Okay, I hope you can all see me. So we mentioned that when we are managing acute asthma exacerbation, that's in a state of an emergency, we are either going to use nebulization or we are going to deliver these drugs by inhalation through NBI. So what we do, we don't have a nebulization kit here.
It's an MPI, right?
Which one?
No.
We don't have one, but it's usually a chamber where we can actually put either our salbutamol or salbutamol and ipratropium bromide, which we can deliver with oxygen. We usually connect it to oxygen, and then we are able to nebulize. Unfortunately, we don't have that setting here, but if you have access to an emergency department, I would encourage you to go so that you can learn how to use that. But most importantly, I want us to demonstrate the device I'm holding is what we call a spacer. Very important, especially for children, because we know that a lot of our clients get these attacks because of inappropriate usage of their drugs. Our patients are on appropriate control medications, but they are having continuous flares because when you give them the inhaler, they blow in the mouth and swallow and go. So when they do that, the drug, they're basically swallowing the drug, so it will not have any action. The target is to get this drug inside the lungs, not inside the stomach. So for our adult patients, I think the technique is the same. So we hold this inhaler with the mouthpiece on the lower end. So you tell your patients to wrap their lips around this inhaler, hold it, and then start to breathe. So once they start to breathe in, as they take in the breath, they will blow. So I am going to, demonstrate. So when they blow one puff, that air that comes out is actually the medicine.
Yes.
So when they blow it into the mouth, they start to take a deep breath until the maximum they can hold. Then you count 1, 2, up to 10, because we want this drug to settle down in the lungs. So when they are done, then they're able to detach it from the mouth and then blow out air gently through the mouth. The only challenge we have is that with our children, you cannot instruct a child that, breathe in, hold, count. They're really uncomfortable with these medications. So that is why we have come up with this device, which is a spacer, which works the same way as what I have demonstrated. You attach, these spacers are available in the market. The cost is between 35 to 80,000 shillings, depending on which brand you get. So you attach this spacer to this end of the inhaler to the end of the spacer, and this end will go to the patient. So we can see the way this is shaped is a mask. Unfortunately, a lot of our spacers will not come with a mask. So you will have to purchase a mask, especially if you have a child less than 7 years old. Those usually above we can instruct. So the idea is that when you blow medicine into this chamber, these children are able to breathe comfortably. You don't have to tell them, breathe in, hold. They just continuously breathe into this, because their medication is, when you blow medicine into this chamber, the medicine will keep in the chamber for a while. So as long as you keep the mask on the patient's nose and mouth, and they just breathe regularly, the way they breathe every day for about 30 to 60 seconds, that is sufficient for all this medicine they have blown to be taken in. This is very encouraged for all our pediatric asthmatics, very, very important, because we have a lot of poorly controlled asthma in children because they are unable to use this inhaler. The mother will tell the child, open your mouth, blow in and run. At the end of the day, they'll come and say these medications are not working, but they actually work, provided we can check the inhaler technique. And that's what it takes me back to, there's someone who raised a question on what should we tell our patients when we're educating them, sending them home. Extremely important. When you control the flare, now the patient is going home. We usually send them home with a reliever, which is the salbutamol, which can be given anytime, and a control therapy. It's extremely important for us to teach them. Actually, for us in pediatrics, we have realized that one of the most important things in management of asthma revolves around the use of this inhaler. Because all the medications, even the steroids, we have inhaled budesonide, but our patients do not have the right technique. So it's extremely important. Use the inhaler, the spacer, and teach these patients to use the right technique. That way they will be controlled and they will have less flares coming up.
So thank you, Dr. Patience. It's very, very important about the spacer, especially in children.
Yes.
And I would also add that in adults, when you mentioned what you were saying, count to 10, if you're breathing at 30 times a minute, you can't count to 10.
You can't.
Right? You're not able to count this. So a spacer is very important in adults too, especially with an acute exacerbation.
Yeah.
Someone
And
okay.
And I will just actually demonstrate, I don't know, maybe you could change the
camera. Camera setting.
So you mentioned that the spacer was, what, 35,000?
Now 35 to 80.
Right.
Dr. Chen, yeah.
I'm gonna show you, how much is a bottle of water cost?
1,000.
1,000. So if you take a bottle of water, hand me the inhaler. Two things, for an adult, you put the inhaler in the end of the bottle, and then you use this. Breathe in and out. So again, what happens is you get a puff, you breathe about 6 breaths, and that'll allow the medicine to get into your lungs. Now, if you happen to have a kid, you actually reverse it. You put the inhaler on this end, and then you open it up and put tape around it. So now that's a mask for a kid for 1,000. So it's not ideal, but I think we all understand that sometimes we don't have quite the resources we want.
Yeah.
And many of the, as I mentioned, many of the studies show that you can actually give 4 to 8 puffs via a spacer and an inhaler and do it every 20 minutes for 3 times. It's really the same outcome as a nebulizer, especially if somebody's not obtunded. If they're obtunded, it's a very different thing. But if they're not obtunded, you get very, very good results with an inhaler and a spacer.
Thank you so much, Doctor.
I think that's, look at that. The other one would be the nasal prong for delivery of oxygen, same COPD. No, this is a tube, a very tube. But I think we are probably familiar with the nasal prong. Oh yes, here. So of course you connect that to your oxygen supply. It can be wall oxygen with, but of course humidified, and then you connect it to the patient. And then you adjust the flow to meet your targets. But we need to start at a lower rating, as Dr. Chen mentioned, and then we can increase gradually depending on the response. Then masks, I think the recommended is a simple mask or the venturi mask. Yeah, but not a non-rebreather, because that will be very uncomfortable for the patient, and then you might also stop the hypoxic drive, and then that will worsen the patient's condition. If they go beyond these simple needs, delivery methods for oxygen in COPD, then that's when we are thinking non-invasive ventilation, and then also if the situation is worse than that, then they might need short-term invasive management, and then they can be weaned off, as was explained earlier. We do not have the CPAP and BiPAP machine here, but if you get to an A&E that is equipped, then you can get to see those instruments and how they work. Get familiar with them, because when you need to use them, like everything in medicine, it's about the techniques and practices have to be learned on the job. Yes, so it's an ongoing process, so you continue to learn with that. Yeah, the elbow bag was maybe for in case we need to do ventilation for very sick ones at the start, and especially if we are going to provide, if you're going to do intubation and all that, you definitely will need an elbow bag. Yes. notice it. And then our oxygen cylinder. Yeah, all oxygen would be appropriate. Thank you.
Okay, thank you so much, our experts, for that demonstration. And I believe our participants have been able to see the different gadgets used in resuscitation during an asthmatic attack. And what has taken my most interest is the spacer. That is not common in most settings, but at least we've got the skills on how to use it in our settings. And for those settings which are able to procure some, it's a good gadget for resuscitation. At this moment, before we go question and answer, I recognize the presence of Dr. Katajira from Makerere Lung Institute. Dr. Katajira, you're welcome to introduce yourself, and I request you to share your experience in managing asthmatic and COPD patients, because I know they appear at your institute on a daily basis.
Well, thank you so much. I don't know if you can hear me.
Yes, we can hear you.
Yeah, Dr. Katajira here at the Lung Institute. I'm actually running a clinic right now. Sorry I couldn't join you. But yes, very nice presentations. I would like to thank the presenters there. Maybe just to share a few observations and well, questions from our clinical experience here. But actually, quite interestingly and surprisingly, perhaps, the commonest risk factor for an asthma or COPD attack is actually patients running out of medicines.
Yes.
That's actually the commonest risk factor for both asthma and COPD exacerbations. And also the other is poor technique of inhalation. So actually, unless you check the technique, you will not know why the patient is getting an attack despite using adequate medicines. It's actually when you realize, it's when they start using the medicines or demonstrating that they realize how so poor their technique actually is. And then probably after that is really an acute exposure to the environmental conditions. So we know, for example, that during the rainy season, we actually tend to see a lot of exacerbations. So you kind of like usually predict that, you know, rainy season, make sure you actually are well stocked on asthma medicines because patients are going to show up. And then after that, we tend to see a lot of infections coming up. And probably also maybe just another observation here is that very, I think, again, something that is surprising some people is that it's very, very difficult to differentiate between asthma and COPD clinically, especially for patients who have both late onset asthma and very late onset asthma. I think historically, COPD was defined as a wheezing disease in people aged 40 years and above. But actually, you tend to see a lot of late onset asthma actually presenting as well later on in life. And it's until you have done spirometry that you realize how surprising the presentation actually was. So I think, again, trying here as much as possible to emphasize the importance of spirometry whenever you can. But we also see a number of COPD patients who have what we call an eosinophilic phenotype. So eosinophilic COPD actually will present as asthma, wheezing, and with immediate response actually to the Ventolin and to the nebulization. It's usually, again, when you have actually done the spirometry and done the CBC and other investigations that you realize that, oh, okay, this is actually just eosinophilic COPD presenting pretty much like an asthma, you know, in the clinic. I'll probably stop here. And thank you again for the wonderful presentation.
Thank you.
Thank you so much, Dr. Katajira, for that, for those additions, and we are grateful that you've been part of us, and we are pleased for that knowledge you've added to us. At this moment, we go to question and answer, and I invite the participants to write in their questions on our chat or to put up their hands, and we shall choose them communicate their questions. Yes, Lynette? Madam Lynette Nabire, we welcome your question. Madam Lynette Nabire, your hand is up. You're welcome to put in your question. Okay, so we shall go back to the questions on the chat. And
So I have a question here is, what is the role of antihistamines in the management of asthma? And then, does the use of steroids create dependency of the bronchioles to such stimulation? If you could talk about those type of patients.
Okay, antihistamines have an effect in asthma, but it is not sufficient to warrant their use routinely. We only involve them when we have other features associated. For example, if the asthma is exacerbated by a viral infection, someone has a flu, then they would benefit from an antihistamine, but routinely, no. The other question was about?
Steroids, chronic steroids, and do they become kind of, dependent on it, so to speak?
The goal of therapy in asthma management is to control the symptoms, reduce hospitalization, and reduce the frequency of the attacks. So we use steroids only during attacks. That is why we mentioned that we use dexamethasone 1 to 2 doses or prednisolone for about 3 to 5 days in the event of an acute asthma. And we don't usually taper down. So the fact that we use our doses for a very short time, it doesn't create dependence. Dependence would only come up in a patient who has poorly controlled asthma or poorly managed asthma, because we know a lot of times in the community, our parents are self-medicating their children on daily prednisolone to try and prevent the symptoms from coming up. So since our course of steroids is really for a short time, we don't usually recommend anything longer than 5 days. It doesn't usually create dependence.
thank you so much. I welcome Mr. Theophilus. Your hand is up, please put in your question. Mr. Theophilus Tim, your hand is up, your question, please. Okay, so another question coming on the chat is, are steroid inhalers sufficient for maintenance or long-term care?
For maintenance, yes. Actually, according to the GINA guidelines, GINA is a guideline we use in management of asthma. They actually recommend now that anyone who's diagnosed with asthma is started on an inhaled corticosteroid for maintenance, low dose inhaled corticosteroid. Because one, this reduces the chances of flares. We have had a lot of our patients start with just the SABA, but SABA will control the acute symptoms. It does not protect the patient from future severe symptoms. That is why the new guidelines recommend that asthmatics should be given a low dose inhaled corticosteroid alongside the SABA. So they can use the inhaled corticosteroid both as a reliever or maintenance therapy, something we call MAT, that is M-A-R-T, maintenance therapy and reliever therapy. So we can use them and they are safe, recommended as the initial treatment given to these patients.
Okay, thank you, Doctor.
Hello, this is Theophilus. Can you hear me?
Yes, please, you're welcome.
Oh, thank you very much. I had missed my chance. Now, I work in one of the emergency departments, and I'm on my annual leave sometime in August. I was requesting if there is a more busier facility having such cases, please let them take me up and use me, or I can take advantage of that.
Sleep is for rest.
So that I'm able to learn more. I need to learn more and add on what I have.
Okay.
Yes, Theophilus, that's
The audience has heard.
we are actually very delighted that we can have somebody who can come up and be ready to give a hand. And we could direct you to Makerere Lang Institute, and specifically we would refer you to Dr. Katajira, who will be of great help to you. Thank you very much for that interest. I welcome Garnet Makanda. Please put in your question.
Oh, thank you very much for the very good presentation. I'm kindly requesting you to just repeat a demonstration of how to use an inhaler. Thank you very much.
Thank you, Garnet. Our experts are going to show you. Please be alert.
Give us the available space on the market. All right. All our inhalers come in this shape, whether it is a SABA, a LABA, and a steroid, they are all the same shape. We usually distinguish them by color codes. I wouldn't encourage you to cram that, but sometimes that's what patients only know. If I use an inhaler that has a brown top, that usually has a combination of a LABA and a SABA. So how we use the inhaler, this inhaler has two parts and they can actually be detached. This is the medicine. This is the delivery system. So we attach this here and hold it with the mouthpiece to the lower end towards the patient's mouth. So you encourage your patients to put this mouthpiece inside the mouth with the lips wrapped around it, and then they start to take a breath. As they start to take in the breath, they blow a puff and progressively take in a deeper breath and hold. So when they hold, the recommendation is that you count to about 1 to 10, and then you release, and then you stop. If you're going to get 2 puffs, you'd have to wait about another 30, 60 seconds before you can give a second puff. That is for the adults or the children who are able to follow the instructions. But for better medication delivery, we have looked at this device, which we call a spacer. This is what is on the market. There are so many other models on the market. They usually come with a mask. Sometimes they will not have the mask. But we have also learned today that we have a readily available spacer on the market. This is a mineral water bottle, which we have created a space at the bottom part of it that actually fits the shape of the spacer mouthpiece. So we can easily put this in here. We're going to see that the technique applies the same as well.
And you can seal it off with plastic or plaster here.
Yes.
So your medicine doesn't flow out.
When you place this here and you blow in a puff of medicine into this spacer, your child, adolescent, or adult is able to casually breathe into this spacer without any pressure. Breathe in, breathe out, hold. Because there's a reservoir that actually keeps this medicine until it can reach inside the lungs, other than making just a puff and then lose it. This is quite, it's not very affordable given our settings. And so someone mentioned what happens if I'm in the village and I don't have a spacer, and doctor actually gave us this technique, which I think is extremely important. This bottle can be used once you place the spacer here for the adults. They can use this end of the bottle to put on their lips, and then they can breathe in and out. Then for our children, we are going to reverse this. So we can put the inhaler here, cut this end and seal it. Many concerns were raised about the sharp edges of the bottle, which is actually very important. So you can seal off the edges so that you can make a soft ending where the child can easily attach this to cover both the mouth and nose so you can deliver the medicine. This has to be taught to all the patients, whether adults or children, because like the doctor has mentioned, one of the biggest risk factors is either unavailable medicines or improper technique usage of the inhaler. Thank you.
Thank you, doctors, for that demonstration. And I believe the person who asked about the use of the inhaler and spacer, and I like the improvisation of the mineral water bottle, especially in our resource limited settings. It's a good in provision, and it can be of better use since these spaces are not common in our resource limited settings. Thank you so much for those demonstrations. We are still welcoming any questions from our online participants.
So I have a couple questions for Dr. Patience. One is, what does she recommend for exercise-induced asthma? The use of formoterol? And when do you, a child who's on steroids, when do you take them off? Or do you take them off?
Okay. So,
inhalers.
Right. So your first question is about?
Exercise-induced.
Exercise-induced asthma. So there's something we call an asthma management action plan. This is something you should teach all your patients. In this action plan, it helps patients to identify what are the severe symptoms, what do I do when I get severe symptoms, and where do I seek help, and how do I increase either the reliever or the maintenance therapy. And we know one of the triggers is exercise. So we have recommended that if a patient's symptoms are usually triggered by exercise, these are patients who, remember we've already mentioned that we recommend now that all our patients have maintenance therapy. And if they have exercise-induced asthma, then they would have to use in the reliever as when needed, because the goal is to make sure that they have a productive life with sensible enough physical activity without limitation. So they can use their reliever therapy when they need to exercise.
And there was the question of formoterol as a drug, it's another beta agonist, and then when do you stop a child who you put on inhaled corticosteroids?
Okay, formoterol is short-acting?
No.
Long-acting?
I think it's a short-acting.
It's short-acting. So it's available as well. We have some inhalers that have formoterol, but commonly most of them are combinations. You find that it's an inhaled SABA alongside a steroid. So you find them actually formoterol, there's a combination that's formonide. There's an inhaler that has a combination, and it's used and safe in children, yeah. Then the steroids, we said we only use steroids in acute exacerbation. So that is
inhaled steroids.
Inhaled steroids.
For maintenance.
Oh, low dose. Yeah, we maintain.
Right.
We maintain.
And-
All children above 2 years old.
And when do you stop it, or do you stop it?
So when you're managing asthma, we recommend that 3 to 6 months from when you start the maintenance therapy, we recommend spirometry and a follow-up visit, where we get now to reassess something we call an asthma management cycle, where you assess, adjust treatment, and review response. So when we assess asthma control, we're able to tell that now our patient is under good control. If they're getting less flares in a month.
There's a comment there. Formoterol is long-acting, bronchodilator, and safe for use in children above 6 years.
Yes.
That's from Dr. Katajot.
Thank you for that, doctor. So we can use these steroids on a daily basis because it is a low dose. We only come in, you might find that you might get an inhaler, for example, formoterol, and we give you a low dose for maintenance, but when you come in with a flare up, we might shoot up and make it high dose for the acute exacerbation. But when we do the progressive assessment and your symptoms are actually coming down, we sometimes taper off and keep you just on the SABA.
Okay, thank you, doctor. We welcome the question from Mr. Brian Nambare. Mr. Brian, you're welcome to give in your question.
Thank you. I'm sorry if I went off, but I had asked a question about expert advice on management of COPD and asthma in palliative care, especially when we are using liquid. Hello? Are you getting me?
No, we've not got the last part.
Yes, I was asking that for any expert advice, especially when we are managing asthma and COPD in palliative care symptomatic plan, because during that management, we normally give oral liquid morphine, which also helps us to manage breathlessness. So I wanted some advice about that.
Okay.
Is it clear?
I don't know if you have an expert online who can help us on that, but for asthma, I would want to think that unless there is another underlying condition, it should be a reversible condition that we want to manage and get somebody out of it. COPD, depending of course on the severity and level of presentation, can benefit from probable palliative care, depending on the situation of the patient. So in that case, then you will have to manage depending on the issues they have. If they have pain that needs morphine, then you probably give them morphine, and then it might have a bit of effect on the breathing. But then you also have to be cognizant of the potential complications of the morphine, especially in higher doses. So about any other effect on that, maybe if there's an expert online that probably knows that, or Dr. Chen who can comment on that, I think that's what I would submit for now.
Thank you so much, Doctor. I invite Dr. Katajira to comment on that if you're online. Dr. Katajira, please. I think he's not online.
Yeah, sorry, I'm in clinic, so just to recap. Hello?
Yes, please.
Hello?
Yes.
Yes, I think, was the question about COPD in palliative care?
Yes,
yes, and the use of morphine.
It's in palliative care.
Yeah.
Okay, so by and large, in palliative care, you want as much as possible for the patient to be comfortable. So you want to relieve their breathlessness as much as you can. So with the use of a spacer and a mask, the patient should continue with their inhalers. That should by far really improve the breathlessness. However, a COPD patient can also get cancer, for example, of the lung. A COPD patient can also get other infections of the lung. So there is nothing actually that contraindicates the use of oral morphine in patients with COPD.
I thought so.
So when you actually assess and the patient is going to benefit from oral morphine, please combine both inhalers and the oral morphine. But oral morphine per se as a standalone that does not add any extra benefit on the treatment of COPD, if it's just plain COPD, unless if there are other indications, because usually, as you know, patients will also continue to have other sorts of pain. So if the patient has pain for which morphine will be of benefit, please add that morphine on top of the inhalers. Over.
Thank you.
Thank you so much, Doctor, for that clarification.
I thought maybe some of the experts could talk a little bit about this question, because it's something that's a little different for me, which is, this one individual says, it seems that India and Egypt's salbutamol inhalers don't work as well compared to GSK. And I'm just wondering, I had my first experience going to the store, they said, which one do you want? You know, which TXA do you want?
Ideally, it should be the issue of the quality of the drugs on the market. I think that's what they're trying to bring up. As they mentioned, we need to get the technique right before you claim something doesn't work. So first make sure you get the technique right, or make the modification like we have seen here, especially in children, and then see if you're getting a response. I wouldn't want to comment on the brands and what they represent, because I think that is beyond the scope of this discussion. Yeah.
Okay, thanks so much, Doctor, for that presentation. And at this moment, I take the opportunity to thank all the experts you've had in this discussion. Thank you so much for passing on your knowledge and skills to our participants. And I also take this opportunity to thank our participants for logging in. And I hope you've achieved a lot in terms of knowledge and skills. And I just want to give a summary or a take-home message for our participants. The take-home message is that asthma is a medical emergency and should be handled as an emergency. And asthma can be classified into mild, moderate, and severe. And all these stages have their own management, and they are determined through proper assessment as discussed. Please note that inhalers are administered 4 to 8 puffs every 30 minutes, when a patient is in an asthmatic attack. As we've seen being demonstrated, there is use of a spacer for children. And in case a spacer is not available, we can always improvise with a mineral water bottle in resource limited settings. It's also important to educate our patients on management of asthma, because when they go home, they are usually alone. And when they're educated very well and they manage their condition very well, they will be coming less times to the hospital settings. Also to note is that aminophylline is no longer used in the management of severe asthma. So please, those of us who have been using aminophylline, of course, we learned it long time back, but we know that medicine is dynamic. After a lot of researches, there are a lot of changes. So let us be able to follow the new guidelines on the management of asthma and COPD. And it's also very important, as we've had in this discussion, that it's important to differentiate between asthma and COPD, and this one is done through assessment and after doing the investigation is the spirometry and all other investigations. And we've seen that the most risk factors for asthma and COPD are patients running out of medicine, poor technique of use of medicine and other gadgets, and of course, exposure to environmental conditions. And especially that's why we see many cases during the rainy season. So, we note that we only use steroids in acute exacerbations. Thank you very much for attending, and thank you so much for all of you who have participated. Especially, we are grateful for our online participants who are always ready to join us. And we believe that you've got a lot of knowledge and skills, and our patients with those conditions will be managed very well after this discussion. At this moment, I welcome our dear panelists to give the closing remarks, but during that time, the post-test is going to be displayed on our screens, and we invite our participants to participate and pick the answers in the post-test. And the online participants can switch on their videos so that we can be able to take screenshots during this time as we are listening to the closing remarks of our experts. Thank you so much. Over to you, Dr. Mandela.
Okay. Thank you once again, especially to the online participants for coming for this discussion today. I would like to echo my take-home message, commonly missed, the asthma management, the action plan. Very, very important for our patients, because we know that sometimes we have to step up their medications. Some of these patients do not know how to identify severe symptoms, and this is our responsibility. Every other encounter you have with a patient, it is your role to make sure that probably this is their last encounter in a very long time, and patient education plays a very important role. Do not give up the habit of teaching patients right technique of inhaler use and counseling of patients, because this is a chronic illness. It's quite frustrating to be in and out of hospital every other month for patients, and their question is always, shall I ever be able to get better, to get off the medications? Let's pass the right information to these patients and encourage them to be patient, adherent to the medications, and to come in when they need help. Thank you so much. Let's keep ourselves updated. The guidelines keep changing every other day. Something new comes up, and it's important for us to keep updated. Thank you to my other experts and panel members. I appreciate.
Thank you very much, everyone, for attending. We could see the numbers at some point. I think we're close to 400 or so. That's quite impressive, that we desire all to learn, and that we continue on the learning journey. Thank you for joining in. I think most of the things have already been summarized. We have to note the issue of the life-threatening nature of an acute exacerbation of both asthma and COPD, and also to look out for those key danger signs: the inability to speak, the silent chest, the cyanosis all those issues that shouldn't be missed at the ED or the OPD. That child who is, not crying at all in the OPD, in the waiting line, somebody need to be able to identify them via triage. They are not sleeping or calm, they are very sick and they need immediate attention. And those are the issues that we need to point out. Then the simple things like a missed dose, a poor technique being the reason for why people come back. This can potentially be avoided, and we need to work on, getting them managed. I think that's it from me, and thank you very much, everybody. Thank you, SID Global, for coordinating this, and also the Ministry of Health. Thank you.
Thank you, Doctor. Thank you, Dr. Harry.
Sure. So thank you all for joining us today, and certainly thank you for the experts here today. I think they've really covered both asthma and COPD in a very comprehensive way. I just want to stress a couple things. One is what Dr. Darlington just said, is you have to be able to quickly assess your patients, see how bad they are. Whether it be, can they speak, are they hypertensive, are they tachycardic, are they diaphoretic? All of those things can really clue you in on how aggressive you have to be with that patient. And the treatments are in large part very similar in terms of using your short-acting beta agonist, remembering you want to treat them, you want to get that in the lungs and not in the back of the mouth. And we talked about how to achieve that with a spacer and a mask with kids, or just a spacer with adults. And a nebulizer can certainly be also used as an alternative. And then corticosteroids, everybody's afraid of using them, but they're very useful for two things. One is for a treatment of acute disease, in terms of the inflammatory nature of asthma, but also the prevention, the maintenance, so that the children don't have, or adults don't have attacks, because it's the recurrent attacks that eventually damages the lungs. And then obviously for COPD, looking at what are the underlying causes. Is it smoking? Is it a charcoal fire? Is it the pollution? All those things we should start to try to address more so than in an emergency department, but as a society in terms of public health. So thanks to all for joining us, and I hope you came away with some things that will help you in your daily practice.
Okay. Thank you so much, Dr. Harry. Thank you so much, our experts. Thank you for passing on your knowledge and skills, and we believe the participants have got the knowledge. I also take this opportunity to thank SID Global for organizing such sessions, because they've enabled health workers in improving their skills in emergency care. We appreciate. We also take this opportunity to thank the Ministry of Health for this initiative. And last but not least, we thank all our dear participants for always logging in and being there also the sessions. And we know that our health workers are always yearning to know more and more, and we are grateful. At this point, I request all the online participants to turn on their cameras so that we are videos, so that we are able to take the screenshots. And we hope all of you have been able to do the post-test and you've submitted. Thank you very much. I also take this opportunity to thank the international participants who have taken part in this session. We are always grateful, and we welcome if there are any international participants to give in your
There was one who was asking
your remarks.
points out of the country.
Theophilus.
I don't know. Somebody said if CPD points apply wherever they are. Yeah.
Okay, any international participants to give in their remarks?
Yes, from Ghana.
From Ghana,
Yeah,
welcome
Nessa
you.
from Ghana. Okay.
Our dear participants from Ghana, please give in your remarks.
So this is Nathan. Hello, this is Nathan. Good afternoon, good evening, good morning.
Good afternoon.
So I work with St. Francis. I work with St. Francis Xavier Hospital in the central region of Ghana as an emergency nurse. I remember one of the questions was, we are not living in isolation. We thank you so much for sharing this piece with us. This is from Ghana.
You're welcome, Nathan.
Welcome. Mr. Nafisa from Nigeria. From
They're all from-
Thank you for attending this session.
Yeah.
Yes, I welcome Mr. Hi.
Okay.
I welcome Mr. Nafisa from Nigeria.
I'm Dr. Nafisa from Nigeria. Thank you for a wonderful presentation.
You're welcome.
Thank you.
Good afternoon. I'm Daniel from Saudi Arabia. Nice to meet you. Yeah. Thanks for the wonderful
Thank you.
presentation. Yeah, thank you.
Thank you. You're welcome. We are happy to have you.
Yeah, thank you.
Yes. Any other international participants? Please feel free to give in your remarks. Meanwhile, we hope all...
from Mogadishu. Thank you very much.
You're welcome. Thank you for attending.
Gabotabo from Nigeria. Glad this is not my first webinar attending with you, and all the topics have been very exciting. I've learned a lot. Thank you very much.
Oh, we are grateful. Thanks for attending.
Yep.
Yes, thank you, our international participants and our participants from Uganda for always logging in and attending. We are grateful. And please note that we always have these sessions every 2 weeks. So 2 weeks after today, on that Friday, we shall have another session. Please always feel free to log in and please register anytime so that you can be able to attend the sessions. Thank you so much. Thank you for attending. God bless you, and I wish you a nice weekend.